Thank you, Sarah. Thanks for the kind words of introduction. It's a real pleasure to be here today, and in the brief time that I've been here, I've been extremely impressed with what's going on here in integrative medicine. Sarah has really taken some of the things that we've been wanting to do at Anderson and implemented them here in a way that that we'll now be looking to you as the example of what we need to achieve. And some of the clinical trials that are ongoing that I've heard about with natural products is phenomenal as well, because it's not about just advising patients on what to take and not to take and leaving them on their own, but getting the data, getting the facts behind this very challenging area that we call integrative medicine. So what I'm going to do for the next little while is first give a bit of a background on what it is we're talking about in this field, and speak a bit about the evidence behind why lifestyle changes should matter. And then I'll describe to you some of the programs we have ongoing at MD Anderson and lace throughout it some of our ongoing clinical trials. The standard for the CME need to disclose this consulting relationship. This is a natural products company in China who helps to support some of the natural products research that we're doing in Shanghai, as well as preclinical at MD Anderson. I'll start with some information that comes from this amazing book called Anticancer by David Schreiber. Those of you who haven't heard of this book, I encourage you to read it. I had not heard of David Schreiber until Dr. Mendelsohn, who's the president of MD Anderson, introduced me to him. And Dr. Mendelsohn is a very conventional, Western-trained medical oncologist. And after he read this book, even though he's been a true supporter of integrative medicine since we started the program over 10 years ago, he said, now I really believe that this stuff matters. And what David has been able to so succinctly do is bring together information in the area of diet, physical activity, exposure to toxins in our environment, stress, social support, and put it together in a way that is very accessible to the lay public, but most importantly is scientifically supported. So I would always have a thumb in the bibliography section as I'm reading it, and every statement and study is well cited. And as you'll see, it's coming not from esoteric alternative medicine literature, but the New England Journal of Medicine and Cell and JCO and other top journals. And David's been able to pull this disparate literature together to tell this clear story that the way that we lead our lives can make a difference. One of the first things that becomes quite apparent, and we all know this in the oncology world, but a lot of people outside cancer don't know this, that we're constantly fighting off mutating cells in our body at all times. And we're all exposed to different cancer-promoting factors, but only a quarter of us will die of cancer. And so that means 3/4 of us have some natural defenses that are going on to keep our body protected even after we get cancer, and of course to keep us cancer-free to begin with. One of the scariest statistics that you're all familiar with is that 1 in 2 men and 1 in 3 women will be diagnosed with cancer in our lifetime. And that now cancer is the #1 killer, as estimated by the WHO worldwide, surpassing heart disease for the first time ever. And a bit of good news, although it's being ignored certainly by the funding agencies and the focus of our medical system as a whole, is that the majority of cancer could be prevented in the first place. The estimates are as low as 50% could be prevented, and as high as 70%. 30% is attributed guaranteed to smoking. That is not controversial. 30% of cancer could just be prevented if tobacco products didn't exist in our society. Another 30% could be contributed to dietary factors. And now, just in the past 5 years or so, we're really starting to understand the role of obesity in risk of cancer, and that's going to contribute another percentage. So, imagine if there was a chemopreventative agent that could prevent half of the cancers in our society today. This is lifestyle, and this is something that is absolutely being underutilized. We are currently in what some would believe is a cancer epidemic in our world. This is the statistics for breast cancer, but the same could be shown for prostate cancer or for colon cancer. And some of this is of course attributed to our aging society. The number one risk factor for developing cancer is, of course, old age. Our risk goes up as we age. And then, of course, screening and better ways of detecting cancer. We're finding cancers earlier. And probably about 40% of this increase can be attributed to that. But that means there's another percentage that's not attributed to that. And the age issue tends to disappear when you start talking about childhood cancers because, of course, they're in children and it isn't an age-based issue. And, of course, there are no formal screening techniques for childhood cancers. This is published in The Lancet just 5 years ago, showing that there's this increase, dramatic increase in incidence of childhood cancers. Then we start to look at the distribution of cancer in the world. And again, this is for breast cancer, with red being the highest incidence, and then orange next. You could overlay colon cancer, you could overlay prostate cancer. And we can see here for breast cancer, the highest incidence is in North America and in countries that you could say are leading a Western lifestyle. So in South America, it's Argentina and Chile, Western Europe, Australia, and you can't really see here in the Middle East, but there's a red dot for Israel, which of the Middle Eastern countries is the one that is the most Western in lifestyle. And this data was collected by the WHO. And in fact, in China, which you see here has the lowest incidence, in some rural towns and villages in China, they couldn't find a single case of breast cancer. Not a single case. Now, there isn't, I believe, probably a single person in this room who hasn't somehow been touched by breast cancer, independent of the fact that you all work at the Moffitt. But a friend, a family member, impossible. And in fact, cancer is being detected in younger and younger ages. My research assistants were commenting to me the other day at some of the patients who were joining our yoga studies are in their 20s and in their early 30s. And this was unheard of back in the 1950s. To have a woman with breast cancer under the age of 50 was just such an anomaly. Now it's the norm and the average. So we're having women on average now in their early 50s, I believe is the average at MD Anderson. And so you start to wonder, is there something different culturally and perhaps genetically about women in China, and they're somehow protected from cancer? And in fact, the evidence would suggest that that's not the case. And this is data looking at women in Shanghai, shown in yellow, and then Chinese women who have moved to San Francisco after a generation, and what happens to their incidence of breast cancer. They became just like the women who were Caucasian women living in the San Francisco Bay Area. So there is key that there's a lifestyle factor going on here. Here you can see a simple correlation between the per capita daily meat consumption and the incidence of colon cancer in women by country. And here you have New Zealand, USA, Canada Down here you have Japan, China, where there is a much lower intake. And, you know, you can't get a stronger correlation here. There's just a straight line that goes down this scatter plot here. We can also look at change over time in the incidence of cancers. And this is some data showing the incidence of colon cancer in India, relatively stable, very low over a number of decades. The USA, relatively stable and high over a number of decades. And here we have Japan. The Japanese need to be very worried about this kind of statistics. We know that there's a growing issue of obesity in Japan, and one wonders, well, why is this the case? Fast food in Asia is so popular. I spend a lot of time in China, and the traditional Chinese diet is so healthy and so anti-cancer, if they're, of course, avoiding some of the fried foods. But things are done in moderation and things are balanced. A meal has just this variety of vegetables and almost always fruit for dessert. And they have a lot of meat products, and even in the vegetarian dishes, they have a sprinkling of pork, so it's very hard as a vegetarian to eat in China. But it's a sprinkling of pork, and they would have, you know, a little bit of beef when they're taking a beef dish. It'd be unheard of for them to sit down and eat an 8-ounce or a 12-ounce, or the absurdity in Texas of a 16-ounce steak in one sitting. That's just not part of their diet, but that is changing with fast food. McDonald's and Kentucky Fried Chicken are especially popular in Shanghai. The number one cancer in Shanghai and Beijing now in women is breast cancer. 10, 15, 20 years ago, that wasn't the case. And so there's a lot of things that are changing in the epidemiology of cancer around the world, and we know that a lot of it, unfortunately, has to do with Western lifestyle. So what David lays out so succinctly in his book is what has happened since 1945 that has increased this incidence of cancer. And he breaks it down into these 4 areas: nutrition, chemical exposure, sedentary behavior, and stress and social support. And I won't talk a lot about the area of chemical exposure, but we'll touch on each of the other 3 areas. This is a graph looking at the per capita consumption of sugar per individual in the United States. And you can see there's just been this dramatic change. Now there's a consumption of over 70 kilograms per year per individual. That's just a huge amount of refined sugar that is passing through an individual's household. And this is the average. So, you know, a lot of individuals don't consume that amount and are very careful. And others are consuming just this massive amounts. And sugar is hidden in all of our foods in our society today. And of course, the USDA requires that there's labeling on everything. And so you can see how much sugar is in your products. And you can see in the list of ingredients where sugar falls, because they have to list the ingredients by the quantity in which it's in the food. And what the food industry has done that's been very clever is that sugar, as you know, comes in many different forms. And if you separate it into all these different forms, then it doesn't fall so high on the ingredients list. So you could have cane sugar, you could have brown sugar, you could have molasses, you could have dextrose, and all of them separated fall relatively far down perhaps on the ingredients list. But if you were to just define it as sugar, in many products out there it's the number 2, if not in some cases the number 1 ingredient. Of course, the soda industry is one of the biggest culprits in our society, and just a standard Coca-Cola, and of course you could pick on any other sweetened soda beverages, has 12 packets of sugar in there. 12 packets of sugar. I mean, and kids are being started on these soda drinks when they're, 4, 5, 6 years old of consuming these massive amounts of sugar. That changes the way your brain interacts with food. It permanently changes the structures in our brain. And we believe that eating foods that have the sugar substitutes that are 0 calories is going to be the quick fix. But the problem is, yes, it does have lower calories, but it changes the metabolism of the body, and it's actually tricking the brain that it's getting sugar, and the brain's processing this as a sugar boost because it has that sweetness and that reinforcing value, but it is not providing any calories. And so people may actually consume more calories because their body is stimulated. The brain is saying, I'm getting calories. And then you actually get no calories. And so the body is craving that even more. Dr. Kumar may be able to speak to the science behind this better from the nutritional perspective. But I believe it's having unintended effects of giving these high sweet 0 calorie drinks could backfire on us. The other thing that's changed dramatically is the kinds of oils that we're exposed to. And of course there's the very poisonous oils that have been outlawed by many states, and McDonald's now cannot have some of these oils. But there's other oils, and in particular soy oil, that is in almost every single product out there. And soy oil is loaded with omega-6 fatty acids, which is a potent inflammatory agent. Now, we need to have omega-6 fatty acid in our body. We need to have omega-3 fatty acid. Both of these are called essential fatty acids, and we can only get them from our plate. So although they're essential, this is something that to keep the body balanced comes from the outside. And in a lot of products, there is naturally a slightly higher balance of omega-6 to omega-3, and the word is slightly, and that's okay, because they work together to turn on inflammation, to turn off inflammation. And the Chinese had it right 5,000 years ago in coming up with this concept of yin and yang and the intricate balance of our body. But what's happened is that there's, as you can see here from this graph showing kilogram per person per year consumption of soy oil, something has gone awry, and this has gone up dramatically. There's a whole political side to this, which is, of course, that big agro is with lobbyists and the agricultural kickbacks is supported to grow products, in particular like soy and corn. And so soy oil is extremely cheap, and it is added to essentially all fast foods and all pre-prepared foods, and even foods that you would think are healthy for you. There is a corn product or a soy oil that's in there. Every salad dressing on the market today is soy oil, by and large. It's not canola oil or olive oil, which has a much better balance of omega-6 to omega-3. This is an example. Again, you can see, references like the New England Journal of Medicine, looking at the change in the omega-6 to omega-3 fatty acid content of some common foods. You can see the eggs is particularly imbalanced, and these are, of course, eggs that are not reinforced with omega-3 fatty acids that you now see on the market. Beef, our cows aren't eating grass anymore. They eat corn and they eat soy. Cows aren't supposed to be eating soy. How is soy a natural part of a cow's evolutionary development? The cows can't process these foods easily. And for those of you who haven't seen the documentary Food Inc., I encourage you to see that, and it outlines this horrendous poisoning of our food chain with this massive development of food by very few number of companies. But essentially what happens when a cow is eating soy is that the flesh of its body is loaded with omega-6 fatty acids, which again cause inflammation. Inflammation is not a good word in the cancer world. You can see back in the 1960s that butter was almost a health food. It has this very nice ratio of a 1 to 2 omega-6 to omega-3 fatty acid content. So you can see that there is this dramatic shift. Of course, saturated fats is going way up, and this is something that our society focuses on and is being educated on, but we're not being educated on this imbalance of omega-6 to omega-3 fatty acid. And you can see this trajectory is not a direction we want to be going. The analogy that can be used here, of course, is that we are delicate machines that need to have the right ratio of different nutrients and products inside us. Just like a two-stroke engine needs to have the right balance of oil to gasoline to run effectively. And we are really throwing things off balance here. Many of you may have seen this comical description of what's going on in the United States. And you may have seen some of these data that come from the CDC. This is mapping obesity, and obesity, as you know, is defined as a BMI of over 30. So this isn't just people who are a little bit overweight, but obese. And you can see back in 1985, there was only a few states that had greater than 10% of the state obese. And we can see here over time, 1991, they needed a new category of 15 to 19% obese. In 1997, new categories for greater than 20% of that state being obese. 2001, now we're at 25% of that state being obese. A new category in 2005, and I believe this is Louisiana and Mississippi, greater than 30% of that state is obese. And here we are in 2009 is the most recent data, with the majority of the states now between 25 to greater than 30% are obese. Now, if you add being overweight on top of that, we know the estimate is 65% of this country is obese or overweight. And the data is irrefutable now on the relationship between obesity and risk of developing many different cancers. And one of the studies actually that's ongoing at MD Anderson, and I know a collaboration between Moffitt that I heard this morning and MD Anderson, is looking at the role of metformin as a product in the treatment of cancer and perhaps even the prevention of cancer. And as you know, metformin is a very old drug to help regulate glucose insulin pathways that are being totally whacked out in these individuals who are taking these huge amounts of sugar in their diet that is, of course, leading to obesity. So what does this mean in terms of the field of integrative medicine? Well, unfortunately, this term alternative medicine is used, and I'm not going to talk much about this because I know Sarah must have given many lectures on this concept of alternative medicine. We don't use this word. That's not what we're about in the field of integrative medicine. And integrative medicine, of course, is much more about the combination of treatments that we know are safe, and may be useful alongside conventional care, and it's all done in a collaborative fashion. This is the definition that comes from the Consortium of Academic Health Centers for Integrative Medicine, which is a consortium of now over 40 medical schools around the country. And they define it quite well and highlight the importance of the relationship between practitioner and patient, that it's focusing on the whole person, very importantly informed by evidence. So there's so much that goes on that isn't evidence-based, and this is alternative medicine, and again, something we don't support. And making use of all appropriate therapeutic approaches, providers, and disciplines to achieve optimal health and healing. And I believe they chose this word optimal health and healing carefully, because particularly in cancer, we're not always talking about cure. We know that up to a third, if not 40% of cancer patients will not be able to be cured, but they will be able to live in a potentially healthy fashion with their disease and managing it as a chronic illness, as we know is so often the case today. So the key to integrative medicine is getting people as healthy as possible and working across multiple disciplines. At MD Anderson, we have an active integrative medicine program with a focus in education, clinical delivery, and research, and I'll walk us through each of these different areas. Our mission, drawing from the definition from the consortium, is really to empower people to become active participants in their own healthcare through integrative medicine education and research-driven clinical care. This is both the patients themselves as well as the providers, the loved ones, and we focus on optimizing their health, their quality of life, and clinical outcomes, again, through research, clinical care, and education across the cancer care continuum. So this includes prevention, patients undergoing active treatment, and then, of course, moving into survivorship. In terms of education, one of the wonderful resources we have is this website that will provide reviews of different therapies. We team up with Natural Medicine Comprehensive Database, which has about 1,000+ reviews of different herbs and supplements, and the pros and cons of these different supplements that can be very useful for the patients to surf on their own, as well as the healthcare professionals at Anderson who are working with the patients, trying to advise them on things they should and shouldn't do, etc. There's a wonderful multimedia portion of this website for patients where they can go and view didactic lectures on the field, or actually learn about how to engage in some of the modalities. So there's chair yoga and different forms of meditation, and learning about how to do brief relaxation massage as some examples. This is the clinical model that Dr. Richard Lee uses. He's a medical oncologist who runs our clinical center. And he draws from the article back in the 70s published in Science by George Engel, looking at a biopsychosocial model to overall health. And the focus, of course, which is the primary focus of Western medicine, is just on the physical, but importantly the need to incorporate psychospiritual and social domains. And so, of course, the main focus of physical within conventional medicine in cancer is chemotherapy, surgery, radiation, and pharmacy, and things kind of end there. Within integrative medicine, the focus in the physical domain is really on nutrition, exercise, things like acupuncture and massage as necessary. And then we team up with our folks in rehab medicine, again, as necessary with our patients. In the area of psychospiritual, it can be things that are relatively conventional, like psychiatry and psychologists doing cognitive behavioral therapy, but then incorporating things such as meditation, yoga, tai chi, many of the programs that I know you have here. And probably the most underappreciated yet very important areas is this social domain. We know that patients who have more integrated social networks, people who are married and in healthy marriages, they live longer. They have better outcomes when they're diagnosed with different chronic diseases. And so we try and help foster a healthy network for individuals. And this can be done through working with social work, working with patients with support groups, and then incorporating things like music therapy, which would be a mind-body therapy, but that is often done in groups. And an example of this is we have a wonderful program for cancer survivors, which is a choral singing group. And the group cohesiveness that they get from that just builds this new social support network that they may not have had. And all this is brought together with Dr. Lee at the helm as a medical oncologist doing integrative medicine consultations. Probably the majority of patients who come in for an integrative medicine consultation come in to hear about an herb or a supplement that they have been told they should take, or that they read about, or that the neighbor's grandmother, gave them this baggie that comes from their ancient tradition, and should they take this or not? And as you know from the statistics I just mentioned, 65%, or probably in Texas, close to 70% of our patients are obese or overweight, and they're coming in saying, should I take an antioxidant? And they're eating fast food and having a high sugar, high fat diet, and they're sedentary. And so Dr. Lee's very difficult job is to try and reorient them that, let's before we start talking about whether you're going to take a pill, let's work on your diet. Let's work on physical activity. Let's get you as healthy as possible. If they're able to manage all of those things, which are probably going to be much more important than taking an antioxidant, and in fact, those things may be more important than even the chemotherapy they're going to be taking, from some of the data that we've collected at Anderson around obese breast cancer patients who have worse outcomes. And so it's about reorienting them to really making changes that could make a difference on their outcomes, and steering them away from things for which there isn't a lot of evidence, as we know, and there could be in some cases contraindications, with the ultimate goal of optimizing their health, which could result in improved chemical outcomes. Improved clinical outcomes. So switching to chemical issues, this is a picture that comes from David Servan-Schreiber's book that is essentially outlining that there are so many active phytochemicals in common foods in our supermarket, and a lot of these things are not. People aren't educated on this. People aren't educated that food can be good for you from a medicinal point of view. It could be neutral, or it could actually be harmful. And the key is to try and find those foods that have medicinal value. Things like garlic, things like cabbage, we know this, broccoli, the cruciferous vegetables, lycopene from tomatoes that we know plays a role perhaps in prevention of prostate cancer, turmeric, which we know is a very potent anti-inflammatory and may play a role in the prevention of many different cancers. There's lots of ongoing preclinical work with all these products, and some initial clinical trials work, of course some of it being done here by Dr. Kumar. What's very interesting that our society does is they hear that green tea is good for you, and so they go to the store and they see a bottle that has ECGC in it, and they see the green tea sitting there in the shelf, and they're like, oh, forget the green tea. I'm just going to go for the high dose of ECGC, and I'm going to take tons of it, because if a little bit is good for you, then more must be so much better for you. And of course, that not only may not be useful isolating the product, but it may actually be harmful. And this speaks to the issue that the whole may be more than the sum of the part, and even when you're looking at different kinds of products. So this is actually looking at antioxidant capacity, which of course may be useful in a pre-cancer environment. And looking at 4 common fruits, right? Blueberry, apples, orange, and grapes. And we all know that blueberries in the square has very potent antioxidant capacity, and we see here that in fact it is more than apple, orange, and grapes on its own. But the combination of all 4 Look at that. I mean, that's synergy. So, if you're thinking what's, the best bang for my buck for antioxidant, you think blueberry, but this would say that's not true. This, of course, is in vitro, so it's hard to know what happens when you get into the human body. But it suggests that there's synergy going on here. This is data published in the International Journal of Cancer just a couple of years ago, looking at the incidence of breast cancer in Chinese population. I believe it was probably hard to find somebody who didn't drink green tea, but women who didn't drink green tea and didn't ever have mushrooms in their diet as the comparison group compared to mushrooms alone or the combination of mushroom and green tea. I mean, this is a huge reduction in the risk of breast cancer, and clearly some synergy going on between these foods. This is David's depiction of what the anti-cancer plate should look like. You can see that there's very little animal protein on there, and the animal protein that is on there is fish, and we know the benefits of omega-3 fatty acids from fish for cardiovascular disease and now emerging evidence in the world of cancer. And the majority of the plate is filled with fruits, with vegetables, with whole grains. And the dessert that you see pictured in the middle is, of course, fresh fruit and berries. And if you wanted to add a little bit of chocolate because our society has this addiction to chocolate, that's fine. Dip your fresh fruit and berries in 70% cacao chocolate, and you're going to get actually a medicinal benefit from that chocolate in and of itself. This is the antithesis of the Western diet. This is not what the Western plate looks like. And of course, we are the marketers of hamburgers and French fries, two products that are probably the most cancerogenic products out there. As I mentioned, beef from our society today, from cows that are fed corn and soy, is loaded with omega-6 fatty acids. You then are putting that in a white bun, which of course is just spiking up your glucose levels, which is driving insulin up, and we know IGF-1 insulin growth factor 1 is relevant in the development of different cancers. And then to make matters worse, what's the main condiment that we put on top of this is ketchup, which of course some think is a vegetable back in the 80s. But we know it's just a vehicle of delivering sugar. So you've got the delivery of fat and the delivery of sugar. And David Kessler, the former head of the FDA, has written a very intriguing book called The End of Overeating, America's Obsession with Food. And he talks about the big food industry and how it's the delivery vehicles for sugar and fat and salt, and in particular sugar and fat. And our brain responds to sugar and fat in the same brain regions, in the same reinforcing regions of the brain as it responds to nicotine, heroin, cocaine. So he doesn't come out and actually say that sugar and fat is addictive, but all the groundwork is there, essentially saying that these are addictive substances. The food industry knows it, and they're manipulating our foods in the same way that the tobacco industry was manipulating nicotine content of cigarettes until society said enough. So it's in Texas, it is very hard to present this plate to a 60-year-old sedentary, overweight man and say it's time to get that 8 ounces of beef out of your daily diet. But this is something that is a challenge that we need to work towards. I throw this up just to show you, just a couple of months ago now in the JCO of, 2011, the role of obesity on prognosis after early stage breast cancer. The same data comes from MD Anderson. This happened to come from I believe it was northern Western Europe, a key relationship between obesity now and survival and recurrence of disease. So both diet and physical activity together are, of course, going to have an impact on obesity. This is data from the JCO looking at colon cancer-specific death after the diagnosis of colon cancer, people with the highest level of physical activity had the lowest chance of death after their diagnosis of cancer. This is from JAMA 6 years ago now, showing that relative risk of death after diagnosis of breast cancer was much lower in women who are moderately physically active. And the good news is that the extreme physical activity wasn't necessary, and in fact may have been slightly worse than moderate physical activity. So we don't have to get our women with breast cancer to go out there and become marathon runners and triathletes. It's just about moderate daily physical activity. And now the recommendation, much to the horror of our society, is that 45 minutes moderate activity 6 days a week. Not every other day, but 6 days a week. And this will create these changes. This, again, is very recent data looking at the incidence of survival after the initial diagnosis of prostate cancer, part of the health professionals follow-up study, one of those these large databases, I believe, in the Northeast, showing that the frequency of physical activity and the intensity of physical activity was important in all-cause mortality as well as prostate cancer-specific mortality. And again, we're not talking about intense amounts of physical activity here, but this moderate amount of physical activity. And you can see these dramatic differences in the people who were walking greater than 3 miles per hour on a regular basis. So, you know, the end of the day is what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day. Now, most physicians don't talk about this. Most patients with breast cancer, for example, who are stage 3, stage 2, and who are worried about recurrence, they're obese, they're sedentary, and they say to the medical oncologist, well, what should I do now? How should I change my life? They're more often than not told, oh, don't worry, dear, we're going to, scan you on a regular basis. If it comes back, we'll catch it early and just go back and lead your life as you were. This, of course, is now potentially unethical recommendation. However, because there isn't a clinical trial showing that if you modify the risk factor, you modify the outcome, it's not unethical as of today. I believe soon it will be, however, and we need to start having these services to help our patients. Let's talk briefly about stress. You all know that your patients believe stress caused their disease, and they say it's the stress in my life, and I know that it was my divorce or the loss of my loved one or the difficulty I've been having with my child, etc. There isn't a lot of evidence that stress actually causes cancer, and this is just one example of incidence of breast cancer due to exposure to different kinds of stressors. And one of the challenges is in the definition of stress. And often the easiest thing to assess in research is the effects of stressors, meaning events that people have in their lives, and whether people who are experiencing bereavement and job loss and other types of stressful life events have an increased incidence of cancer. And as you can see here, that is negative, and that's the case in a lot of studies. What's much harder to assess is stress, which is this more complex construct of how somebody responds to the stressful life event in their life. So two people who have the unfortunate experience of losing a loved one, they may not necessarily respond to that in the same way. And a person who has a lot of social support in their life may not have as much difficulty responding to the loss of a loved one as the person who is on their own. Then they lose their loved one and they've lost that social support network, and they spiral into depression and complicated grief, etc. And so there is some research suggesting that there's an interaction between social support and the experience of stressful life events. And you can see that here, where the highest incidence in the development of cancer was in people who were experiencing a lot of stressors, who also reported a low amount of social support in their lives. And for the other combinations, that wasn't the effect. So social support, we know from a lot of research, is a powerful buffer against stressful life events in one's life, and can, as I mentioned before, is related actually to all-cause mortality. This is from a different database, just looking at individuals who have one or more friends compared to individuals who report having no friends. Again, Journal of Clinical Oncology, a well-respected journal, showing that social support has the impact on the risk of cancer. We're very lucky at MD Anderson to have Dr. Anil Sood, who's a gynecological oncologist whose laboratory focuses specifically on looking at the effects of chronic stress in murine models. Being a gynecologist, his main focus is looking at ovarian cancer, and he's done elegant studies looking at the effects of psychological stress in these murine models on progression of disease. And the labels aren't on these graphs, but this is tumor weight, and this is number of nodules, so essentially the spread of disease. And the first two bars on each graph, the first bar represents the control group who don't get any stress, and the second bar is a group that is exposed to psychological stress after tumor inoculation, actually for a week before and then 2 weeks after tumor inoculation. And the tumors are much heavier, much larger, and the spread of disease is quite profound throughout the whole body. In the mice who aren't stressed, it's really confined to the space of the injection. This was actually not that novel, and there was research done by Sklar and Annesman back in the 70s and the 80s showing this effect of stress on progression of disease. What was very novel, and why this was published in Nature Medicine, is Anil was able to show the mechanism of how psychological stress was driving progression of ovarian cancer. And he did that by manipulating norepinephrine, by putting propranolol on board. So patients, the mice who were exposed to propranolol, which is a beta-2, and specifically beta-2 receptors, psychological stress had no effect on their disease. They looked identical to the animals that weren't stressed, both in terms of tumor weight as well as spread of disease. So this, of course, is blocking the effects of norepinephrine, and we know norepinephrine is a key stress hormone that goes way up when people are exposed to psychological stress. This is data that was published just at the end of last year in the journal Cancer Research, again in collaboration with Anil Sood, but Steve Cole being the lead investigator at UCLA, looking at the relationship in this same psychological stress model, but in a breast cancer murine experiment, and looking at the drive from the primary tumor to becoming metastatic. And he was able to image this, as you can see here, as an example over the course of 1 month. And this is an example, of course, of the stressed animals, where you can see the development over time in the metastatic site. And the animals that weren't exposed to stress did not have progression of disease. And what he shows here also is the same thing with the beta blocker. So here we have propranolol and stress, because the breast cancer is confined to the site of the injection, just like the control animal. The stressed animals, here we actually see 2 metastatic sites. If you inject the animals with isoproterenol, which is essentially a norepinephrine agonist, the same massive spread of disease throughout the body. He's also, I don't think I have the slide for it, he also looked at a drug that blocks macrophage activity, and by blocking macrophage activity you also block the effects of stress on the spread of disease in this breast cancer model. So this is clearly documenting that there's a relationship between stress hormones and progression of disease in animal models. Now we know that that depression, this is a meta-analysis from cancer showing that depression is related to survival after diagnosis of cancer. And recent data, again published in the JCO, in stage 4 breast cancer patients, and looking at the relationship between change in depression across the course of the year of joining of this trial, and that relationship with overall survival. So it's a relatively small database, but the women who had an increase in depression, independent of disease status and independent of disease characteristics, that was an independent prognostic indicator of overall survival. Increase in depression across the course of the year versus a decrease in depression across the course of the year. This is data from, of course, another continent, coming from the Shanghai breast cancer survivor study, looking at quality of life and psychological factors as predictors of both recurrence and total mortality. And we can see here that social well-being is almost this dose-response effect, that the greater the social well-being of the individual, the less their chance of recurrence, and the better their overall survival. This is data just published at the beginning of this year, again coming from a collaboration between Steve Cole, Neil Sood, and Susan Lukendorf out of the University of Iowa, looking at the relationship between social support and what's going on right there at the tumor microenvironment of women with ovarian cancer. So these patients complete these self-report questionnaires, and then at the time of surgery, they're getting samples from the site of the ovarian cancer, and seeing that the levels of norepinephrine in the tumor is directly correlated with social support. And this is independent of stage of disease. So the higher the social support, the lower levels of norepinephrine in the tumor, as well as in the ascites. And I just showed you the data, the relationship indirectly of norepinephrine driving disease forward in ovarian cancer patients who, in the mice model. Now, coming out, it's in press and coming out in the next few months, data collected from, I think it's around 2,000 breast cancer patients at MD Anderson, retrospective chart review. The patients who were taking beta blockers had a decreased chance of recurrence. I believe the patients who were taking beta blockers lived longer. They were taking beta blockers for reasons, of course, totally separate from stress and separate from their cancer, for heart disease and that kind of thing. But we're starting to learn a lot more about these stress hormones and, of course, disease-related outcomes. In a wonderful article in Nature Reviews Cancer, all of this is outlined of the role of how psychological processes, and when they're processed, has this downstream effect on ACTH, sympathetic nervous system arousal, and now we know gets right into the tumor microenvironment, has an impact on the immune system, which we've known for decades, which is much more recent, is that it has a direct impact on cancer-related processes like VEGF and upregulation of SARC activity and others. So in the area of mind-body, there are so many different things we know we can do to help people manage the stress. A lot of these are conventional things that are cognitive behavioral therapy, psychotherapy, and then things that fall more in the range of integrative medicine, yoga, tai chi, etc. You have a lot of these wonderful programs here. I know I'm running out of time, so I'll quickly run us through some of the research A couple of years ago now, we published a study showing that pre-surgical stress management was useful for men with prostate cancer, not only for their mood around the time of surgery, where we see a stress management group compared to supportive attention compared to the usual care. Stress management had the least level of mood disturbance, but even a year later, just from pre-surgical stress management, quality of life was better, in fact, in both these groups compared to a usual care control group. And we recently published in Psychosomatic Medicine immune-related outcomes. So from baseline to 48 hours after surgery, we see an increase in NK cell cytotoxicity if they were in the stress management group, and a decrease if they were in either one of the other two groups. So both a psychological and behavioral benefit from these types of programs. We have a lot of ongoing research in the area of mind-body trials, all of them NCI sponsored in some form or another. The most recently funded mind-body study is this large Hatha Yoga study. It's incorporating yoga into the radiation plan for women with breast cancer. This will be a phase 3 study randomizing 600 women to a yoga group compared to a stretching relaxation group compared to usual care, to really show that, or to really see and hopefully show that this type of program is useful and goes beyond just simple aspects of relaxation and stretching. In the area of acupuncture, we've been particularly active in experiments looking at the benefits of acupuncture to help with saliva flow after radiation to the head and neck. We did a small study for patients who had already developed xerostomia, and in collaboration with colleagues in China, did a study to try and prevent the development of xerostomia when patients were actually undergoing the radiation treatment. So here they had radiation treatment for 7 weeks, and we incorporated in this randomized trial of around 85 patients either acupuncture or they just received usual care, which was nothing, of course. And you can see that they're developing, both groups are developing symptoms of xerostomia over time, but much less if they were in the acupuncture group. That's a subjective measure of their report, and of course it wasn't a blinded study. But we can see here in a more objective measure of saliva flow, yes, saliva flow is impacted negatively in both groups, but much less if they were receiving the acupuncture. And the radiation oncology colleagues in China were quite intrigued by this data, and we can see it's 1 month out, and acupuncture ends on the last week of treatment. And they said, well, but how long is that effect really going to last? And xerostomia really gets bad, and you start to see the difference between who's going to have it and not 6 months later. Well, this is 6 months later on a subsample of around 65 patients. The differences are even larger here, with fewer symptoms in the group that had acupuncture 6 months earlier. They haven't had any acupuncture since radiation ended, with still the saliva flow differences. So we're pursuing this research, and actually just had this R01 funded to do 150 patients at MD Anderson, 150 patients in Shanghai as a more definitive, as you could call it, phase 3 clinical trial. Within our CCOP, we're doing a similarly phase 3 clinical trial for treatment. So after it's already developed, to see if we can have an impact on that. And we just recently completed this neuropathy study, and I believe that this is another very fruitful area that can be useful for acupuncture, because there isn't a lot of conventional treatment out there. This is a horrible side effect that patients get. And so the last area to just touch on is natural products. Dr. Pei-Ying Yang has a lot of ongoing research preclinically. I'm happy to see that you guys actually have a lot of phase 2 clinical trials already with natural products funded by the NIH, which is wonderful. We have some trials in that area, but not as many. And What's important to know, and I know I'm preaching to an educated group here, is that these aren't just, foods that are potentially useful. These are foods for which we know from all our preclinical scientists have very potent activity, targeting the same pathways that the conventional drugs are targeting. What's interesting about natural products is they can actually target multiple pathways at the same time. And so we all know the future of cancer medicine is this concept of multi-targeted therapy. And in the conventional world, that means you're going to have different drug companies working together and have this molecule for this pathway, this molecule for that pathway. Well, some of these products, just 3 listed up here, hit multiple targets and multiple pathways with one product. We've been working a lot with this product called Huashansu, which you see pictured here in its alive form, and you see pictured here in the pharmaceutical form. It's the extract from the skin of this poisonous toad. We did a phase 1 study in Shanghai. This is a commonly used agent in traditional Chinese medicine, but has never been formally researched. And so we did a standard dose escalation toxicity kind of study. Didn't see toxicity even at 8 times the standard dose that they use, and actually saw some activity at the lower levels. We see here there was one patient who had a 20% reduction in tumor mass. This is the only agent that this patient with stage 4 disease had seen, and you see it pictured here with stable disease that lasted for over 11 months just with this product. Pei Yang and her colleagues at MD Anderson are actually looking at a very similar product that comes from oleander. Both have the same mechanism of action of being cardiac glycosides. And they also, in fact, have found, and haven't published yet, but should be coming out soon, that the activity in their phase 1 clinical trial was at lower doses. And so this is an area of research that's being actively pursued. So we can see from this quick tour that I've given you in this area of integrative medicine, where we're really trying to expand this definition, that nutrition, sedentary behavior, obesity, and stress management can have very important effects on clinical outcomes. And it's something that needs to be managed within our patients today. One of the biggest challenges from the funding agencies is this is all being done in a very reductionistic fashion. So the NIH has been funding, big prevention studies and post-diagnosis studies of let's increase fruit and vegetable consumption in the WELL study, or let's increase their physical activity and see how that impacts outcomes. And this is a study that was published just a few years ago in PLOS Med, showing the relative risk of survival of 4 different health behaviors. I think it was smoking and alcohol consumption, physical activity. I can't remember what the 4th one was. Probably in some way of defining healthy eating, and that there's a synergistic effect here that, if you do one, that's a lot better than 0. But once you start adding more health behaviors, the outcomes become better. This is from the WELL study, which did show a slight benefit of increasing the main purpose of the study is breast cancer patients after treatment increased fruit and vegetable consumption to 9 servings a day. And the control group were just given the recommendation of the standard 5 a day. And they had a modest effect. But then in this post-hoc analysis, they went and looked at change in both fruit and vegetable consumption as well as physical activity. And if they did either one of those or none, you see these first 3 lines here, and they're all overlapping. If they increase physical activity, it didn't have much difference, than not increase fruit and vegetable, didn't really have much difference. But if they did both, look at the bump in their survival, increasing both fruit and vegetable consumption and physical activity. This is synergistic. So by doing this reductionistic research, we will be concluding potentially, and what medical oncologists are actually telling breast cancer patients and others, that it doesn't matter. Because when looked at alone, the data suggests it doesn't matter. But if they do these things together, then perhaps it will matter. There's very little research that's been funded in this area. Dean Ornish, who of course has shown that lifestyle can reverse heart disease, has started to do this in prostate cancer patients, showing that men who are under active surveillance, who undergo this massive lifestyle change following the Dean Ornish method, have a decrease in PSA, have an increase in the ability of their serum to fight prostate cancer in vitro. He's looked at change in gene expression and shown change in gene expression. He's looked at change in telomerase, which of course is in every single cell in the body. And Barbara Anderson has published some amazing data in a much larger clinical trial of women undergoing chemotherapy for breast cancer. I think the reason that she hasn't gotten a lot of attention is because she's this clinical psychologist. She really emphasized that this was a psychological intervention. Well, yes, it was a psychological intervention, but it was a year-long intensive intervention where they were taught about diet, they were taught about physical activity, they were taught about stress management, they were given comprehensive lifestyle change. And these are the survival curves. This is recurrence of disease, breast cancer specific survival, and overall survival. Those curves are so separated. I mean, if a medical oncologist had these kinds of curves for the effects of their chemotherapies, this would be a home run. This would be, a grand slam approved by the FDA within milliseconds. This is just lifestyle changes. The most recent data she published in Clinical Cancer Research just at the end of last year took the women who actually had a recurrence. And, this intervention was for a year, and these were all stage 2 and stage 3 cancer patients, so they lived for a number of years disease-free. So the women who had a recurrence, she looked at survival after recurrence, based on the groups. Dramatic differences, a twofold increase in survival after you have a recurrence. If way back when you got your chemotherapy the first time, you learned about all these healthy skills. So these things have a lasting effect, this type of comprehensive lifestyle change. We need much more data in this area, and this is the kind of research that we're moving towards now across the cancer care continuum, to look at what we're prescribing to our cancer patients in the clinic and trying to actually test it in a more formalized, randomized clinical trials, understanding what the pathways and the mechanisms are to ultimately change cancer care for our nation and the world. Thank you for your attention. I don't know if we have time for questions, because...
In the interest of collaboration, I'll take 2 questions for those of you who can stay.